Oh, that's better. Yeah, because I have done this also.
I am actually common.
We need to move right on at the end. That was horrible.
Make Karl a little bit. I'm happy that I haven't seen
survey Chairpersons
in my life.
which may well be the conflict of interest. Without that, the others will probably be a little more straightforward. Shall we start?
Yeah. Please go ahead.
Good afternoon, ladies and gentlemen. My name is Salim Yusuf from Hamilton, Canada. And on my left is Jeroen Bax, the next president of the ESC. Congratulations and commiserations, Jeroen. We have 4 important presentations, some of which will make us sit up and rethink hypotheses and our ideas of mechanism. Our first speaker is Professor Michel Boehm from Homburg, Saar, and he's going to talk about the effect of implanted device-based impedance monitoring with telemedicine alerts on mortality and morbidity. May I remind you there'll be no questions from the floor. There will be a discussant and then a panel discussion after each presentation. Michel?
Thank you, dear Chairman, members of the committee, and ladies and gentlemen. It's a pleasure for me to report on behalf of the investigators and the committees of the OptiLink study the results of the effect of implanted device-based impedance monitoring with telemedicine alerts on mortality and morbidity in heart failure. Before I start, I would like to give tribute to the former chairman of the study, the co-chairman Helmut Drexler, who can unfortunately not be among us anymore. These are the center. This is a German study which was performed in 65 active German centers. Here you can see the list of contributors, and they deserve the credits for the results. The study was overseen by an executive board, co-chaired by Professor Johannes Brachmann. We had an event committee and a data safety monitoring board chaired by Stefan Anker with Dr. Swedberg, Valens, Tavazzi, and Pocock. These are the disclosures. All participants received scientific support of Medtronic, US, and the study was sponsored by Medtronic. It is known in heart failure that before a decompensation occurs, there is volume overload and increase in pulmonary pressures, and this occurs before signs and symptoms develop in heart failure. Therefore, the primary objective of OptiLink was whether intrathoracic impedance monitoring with an automatic wireless telemedicine notification system compared to standard clinical assessment is superior to reduce all-cause death or cardiovascular hospitalization. The baseline data and the protocol has been published in the European Journal of Heart Failure, and you can refer to this document. The inclusion criteria of OptiLink was an indication of an ICD or CRT-D device. The indication was done at that time when the trial started according to the SCATEF criteria for ICD or according to the European guidelines of the ESC for heart failure from the year 2008. In addition to these indications, patients had some additional criteria for inclusion to make them more prone and to put them at a higher risk for cardiac decompensation and deterioration. And this was heart failure, hospitalization within the last 12 months, oral diuretic increases within the last 30 days, and increased levels of BNP or anti-proBNP, where the anti-proBNP concentrations here, the thresholds were adjusted to the age of the patient. Exclusion criteria were all conditions which might alter intrathoracic impedance, like chronic renal failure, which was measured at the eGFR on an increase in serum creatinine, and also pulmonary obstructive pulmonary disease. So the intervention access arm had a telemedicine-guided alert system. The particular and important thing here is that the alert was not audible to the patient. The idea here is that the patient is not scared, and we do not artificially increase presentations and hospitalizations. And this was compared to a control arm under standard clinical assessment. Patients were implanted and enrolled and then assigned to either the access arm or to the control arm. There was a follow-up every 6 months during the completion of the trial. The follow-up was done in 18 months in every patient. There was, if consented, an extended follow-up, which was a recommendation of the DSMB. And the primary endpoint chosen was the composite of all-cause mortality and cardiovascular hospitalization with an analysis to judge the time to first event. Secondary endpoints were all-cause mortality, cardiovascular hospitalization, the composite of all-cause death, heart failure hospitalization, cardiovascular mortality, and all-cause hospitalizations during follow-up. So the study was designed to include 1,000 patients. For an alpha of 5%, we needed 725 patients, but since we were knowing that some patients might not enter the study, it was designed on 1,000 patients, so we had 80% power to detect 8% difference in event-free survival. So these are the statistical techniques. Log rank tests were performed and stratified Cox proportional hazard regression models to look at the hazard ratios. A second important thing is that when a care alert of an impedance threshold crossing was received by the physician, he followed a detailed algorithm. So when an alert arrived to the physician, he had to call the patients within 2 business days and arrange the next step. This could be hospitalization, or the patient had to transfer the data during the next days. And if there is no further crossing, the patient was left. And if there is still a crossing, then there was an intervention done by the physicians, which is in the first instance healthcare advice. It could be putting the patient to the hospital or asking him to come to the office, or increasing medication or change of medications. So this is a patient flow. We enrolled 1,002 patients. 2,002 were randomized. Some patients died, 59 and 63 during the trial, and several patients withdraw consent, and these patients were analyzed according to intention to treat with a mean follow-up of 22.9 months. So these were the baseline characteristics. Patients were predominantly male. The majority had ischemic cardiomyopathy. Ejection fraction at average was below 30%, and patients were on a quite intensive treatment, including beta blockers, RAS inhibition, diuretics, and in particular 69% and 70% aldosterone antagonists. So the intervention effectiveness, which is important, was the following. In those patients who were on the alert, there were, in the interrogation of the device, 1,748 threshold crossing. From those, these occurred in 80.5% of the patients, so 19.6 were without any alerts during follow-up, and it were transmitted 75.7 alerts to the physician. When these alerts were transferred, then the intervention was followed in 85%, which means 15% roughly did not followed by an intervention by the physicians. Interestingly, when there was an alert, a threshold crossing of fluid in the lung, there were only 37.7% of patients who had signs or symptoms of heart failure. Action was taken in those patients where where it received the physician in 46.9% of the cases. So this is the primary outcome, which had been achieved under these conditions. And you can see that the primary composite endpoint composed of all-cause death and cardiovascular hospitalization was not different between the intervention group and the control group. Here you can see the p-values and the hazard ratios. Among the different subgroups involved in the study, there was no heterogeneity in the outcome of this intervention. There was no interaction with age, gender, cardiovascular disease, class of heart failure, hospitalization, device type, history of atrial fibrillation. So homogeneity through all the subgroups. And when we look at the individual components of the primary composite, these Kaplan-Meier curves were superimposable. As you can see, no significant difference in all-cause death and no significant difference in cardiovascular hospitalization. If we look at the secondary endpoints, these were the summary of the primary. Here are the secondary endpoints. There is no significant signal for death from all cause. First, heart failure hospitalization, although when it was adjusted to the pre-study hospitalization, there was a small signal and there was no difference in cardiovascular death. So the conclusion are that the Optilink device, under the conditions and circumstances used, did not show superiority of this specific intrathoracic impedance measurement and this telemedicine-based heart failure disease management strategy over standard clinical assessment. Telemonitoring, and these are the findings also of the trial, depends on multiple factors. This is first a successful transmission of the signal, which is dependent of the adherence of the patients to the system and the adherence of physicians to the signal, meaning subsequent interventions, medical increases, and also patient adherence to the medical advice he is given. Thank you very much for your attention.
Mr. Chairman, ladies and gentlemen, as we have seen, these are my disclosures. As we have seen in the presentation from Professor Boehm, the Optilink trial was neutral. And even so, I want to congratulate the study leadership and the study investigators for pursuing this difficult trial over several years and randomizing so many patients and follow them according to what they had set out to do. Now, by doing so, they gave an answer to this design. And it was also neutral on the components of the primary outcome, as you saw, completely neutral. So why did this study result in neutral results? Well, the concept and the hypothesis may be wrong. It's not possible to influence outcome by measuring impedance the way they did it. Maybe the design was wrong. And so the endpoint they used was wrong. So you cannot just measure these type of effects and in this type of setup and influence outcomes. I would guess, my suggestion is that it was all components here that might have been wrong. Obviously, we won't know from this trial more than the way it was done. We have a clear result. So let's look into what we saw by the presentation. Here are the transmitted fluid threshold crossings. And as you see, in about 20% of them, there wasn't even a transmission. So something in the whole setup went wrong. Many were lost because there was no transmission as the patient wasn't hooked up to the system enough. Another, and I think very important part here, is reflected by the fact that only 37% of these fluid threshold crossings were associated with worsening symptoms. And we all know that worsening symptoms are extremely important in the assessment of worsening heart failure, and which leads the patient to seek help for and be admitted to hospital. So let's look into what's else out there in the area. This trial we have just seen was designed in 2008, and now 7 years later it's presented. This is another trial based on the same concept, impedance measurement, the .HF using about the same technique but from another manufacturer, and or actually from the same manufacturer, and you see, as you see here, this trial was stopped prematurely because of slow recruitment, and here there was an indication of an increased risk in the intervention group. This study was designed a year earlier and published already 4 years ago. Another trial in this field were measuring, using this device and measuring some kind of signals, was the TLE-HF trial from Germany, where actually Dr. Boehm was involved, another completely neutral trial. This trial was designed also in 2007, published in 2011, 4 years ago. So a lot has happened in this field, and before we saw this study result. A third trial I want to bring to your attention in this field was the TLE-HF trial from US. It's a huge trial, 1,600 patients, and ending up completely neutral. But in this trial, they tried to incorporate measurements of symptomatology. However, a major problem in this trial was that there was a 50% withdrawal rate. And obviously, if you have such a withdrawal rate, it will become very difficult to have a reliable assessment of outcomes. This trial was also designed in about almost 10 years ago and published 2010. So a lot has happened over the last 5 years in our knowledge in this type of technique. This trial we actually discussed in a letter, and we thought that the whole concept was lacking appropriate assessment of patients' symptomatology and patients' involvement. And that was reflected by the high withdrawal rate. You need to make up a much, much better partnership with the patients in order to achieve this type of assessment. A way to do that would be to include various clinical assessment, and that was suggested by Dr. Packer many years ago, what he called a composite clinical endpoint. And such an endpoint was actually used in the in-time study where Dr. Hendricks and colleagues actually set out to assess the combination of mortality and worsening symptoms. And this trial, and interestingly, they focused on the worsening and actually could show that fewer patients worsened by the telemonitoring as done in this trial. And this was also designed around that time, but they included the clinical composite endpoint, which might reflect that the type of outcomes should be expanded and be differently measured. So my conclusions would be that in heart failure trials, endpoints composed of only sign assessments will probably give underpowered results. Sign is not the only thing that's important in worsening heart failure. Such endpoints do not reflect the important symptomatology and functional status present in heart failure. And composite clinical endpoints should be explored where functional status and symptoms are included in order to allow important treatment effects to be evaluated properly. Thank you.
Well, thank you very much, both Michael and Karl. That's a comprehensive discussion. Is it possible that the parameters we are trying to monitor may not be the right parameters hemodynamically, because study after study focusing on hemodynamics, starting from the old Swan-Ganz catheters to now, has not come up with clear answers. And maybe instead we may want sensors that monitor neurohormonal activation.
Indeed, this is a volume and water assessment of the lung. It's very specific for overload in the population with heart failure, but it's not 100% specific. So also some patients had pneumonia. Some patients, we had one with amiodarone pneumonitis. Even pregnancy in previous registries can produce threshold crossings. So this is one of the reasons why the endpoint cardiovascular hospitalizations and not heart failure hospitalization was taken, which is a little bit unusual for a heart failure trial. And the other reason is in this area that we also want to capture arrhythmic events like atrial fibrillation, causing congestion, or preceding a decompensation. So that is a choice of the endpoints. Having just pressure is something which sounds more specific for heart failure, but when there is a kind of inflammation, then the pressure-volume relationship is shifted to the right and you get easily fluid overload. I think this is an open discussion. Maybe a head-to-head trial would help here. But I think either technique has its advantages.
Actually, my question was totally different. What Karl showed was 4 or 5 studies, all neutral. So I think it may be time to ditch the hypothesis. And I can see clearly in people coming to an emergency room, NT-proBNP has prognostic value. Yeah. We also have diagnostic value. So could it be that some kind of finger prick testing for NT-proBNP, like our diabetic patients do, might be something worthwhile? I wonder what, Karl, you think?
During these years, since this was designed, obviously we have learned a lot about biomarkers and in general, and BNP measurements, NT-proBNP measurements in particular, as they seem to be important for the assessment of heart failure status, and also that hemodynamics in a way could be assessed by a device like the CardioMEMS type of measurements. But I think in a way we should use the symptomatology better and incorporate that into the assessment and not only rely upon objective sign measurements.
Great. Well, thank you very much indeed. That's a very important study. Thank you both.
And then the next study will be presented by Dr. Barry Greenberg, coming from La Jolla, the United States. And he will share with us the CUPID-2 trial, which is a phase 2b trial investigating efficacy and safety of intracoronary administration of AEV1 circa 2A in patients with advanced heart failure. Barry, please.
Professor Bax, Professor Yusuf, members of the European Society, and honored guests, I'm pleased to present the results of CUPID-2 on behalf of the 250 patients who participated in this study and for the 67 investigative sites and clinical teams in the United States, Europe, and Israel that participated in CUPID-2. Here's my conflicts. CUPID-2 was run by a variety of committees. Those and the members are listed on this slide. As background, circuit 2A is known to play a critical role in calcium homeostasis within the cardiomyocyte. A deficit in circuit 2A activity has been recognized as playing a key role in the failing heart, and restitution of circuit 2A activity by gene transfer has been shown in myocytes derived from failing human hearts to correct abnormalities in calcium flux and also to improve function of these cardiomyocytes. The rationale for CUPID is based on the fact that gene transfer with AAV1 circa 2A has been shown to improve cardiac performance and outcomes in a variety of small and large animal models. An earlier pilot study, CUPID-1, suggested that AAV1 circa 2A stabilized or improved several independent measures of patient well-being and cardiac function, and it was associated with a reduction in the recurrent heart failure event rate compared to a placebo-controlled population. Thus, CUPID-2 was designed to confirm the beneficial effects of the percutaneous intracoronary administration of AAV1 circa 2A on clinical outcomes in patients with moderate to severe heart failure symptoms and reduced ejection fraction, and to assess the safety of this approach. The eligibility criteria are shown on this slide. Basically, patients with symptomatic heart failure due to either ischemic or non-ischemic etiologies, reduced ejection fraction, who were receiving good medical therapy and stable for at least 30 days were considered candidates for the clinical study. The exclusion criteria are shown on the slide and are typical for a study of this type. In CUPID, AAV1 circa 2A was administered via percutaneous intracoronary artery perfusion. Basically, 60 mLs of drug was given in up to 3 infusions, depending on the anatomy. Patients were pre-treated with low dose of systemic nitroglycerin, and the overall aim was to provide diffuse homogeneous left ventricular exposure to AAV1 circa 2A. The primary efficacy endpoint was time to recurrent heart failure-related hospitalizations in the presence of terminal events, including all-cause death, transplantation, or implantation of a durable mechanical circulatory assist device. The secondary efficacy endpoint was time to the first terminal event, defined on the slide. There were a number of exploratory endpoints, including change in New York Heart Class, biomarker, 6-minute walk test, and the Kansas City Quality of Life Questionnaire, and a number of safety endpoints were also evaluated, and they're listed on the slide. Monte Carlo simulation performed using data from CUPID-1 was utilized to determine our sample size. We found that we would require 186 events in 250 patients who were followed for a mean of 18 months to have an 80% power at the 0.05 two-sided significance level to detect a recurrent event hazard ratio of 0.55. That is a 45% reduction in events using a joint frailty model. The overall design is shown on this slide, and after screening and randomization, patients received either AAV1 circa 2A at a dose of 10 to the 13 DNase-resistant particles or placebo. All patients were then followed for at least 12 months and then entered into a long-term follow-up period. The results are shown on the next series of slides. The 250 patients who were randomized were allocated to receive either AAV1 circa 2A, and of these 123 patients, 121 were ultimately treated. Of the 127 patients allocated to placebo, 122 were treated. These treated patients made up the modified intention to treat population that the primary efficacy analysis and secondary efficacy analysis was based on, and these are the results that I will present to you today. Here are the baseline characteristics of these patients. There were no differences for any of the characteristics between the placebo and the AAV1 circuit 2A treated patients. Overall, the patients averaged about 60 years of age. Approximately 80% were male and 80% were white. Based on these characteristics, patients were judged to have moderate to severe heart failure. An ischemic etiology was seen in approximately half of these patients, and overall the population was receiving what would be considered guideline-recommended medical and device therapy that was appropriate for the severity of heart failure that the patients had. This slide shows the primary efficacy endpoint result. Of 232 recurrent events that qualified as primary endpoints, 128 were in the placebo group and 104 in the AAV1 circuit 2A group. Thus, treatment with AAV1 circuit 2A failed to improve the rate of recurrent events. The hazard ratio, confidence intervals, and p-value are shown on the slide, and on this panel, the recurrent events are shown in a Kaplan-Meier curve depiction. For the secondary efficacy endpoint, of 65 terminal events, 29 were in the placebo group and 36 in the AAV1 circuit 2A group. Thus, treatment with AAV1 circuit 2A failed to improve time to first terminal event, hazard ratio, 95% confidence intervals, and the p-value are shown, as are the Kaplan-Meier curves for the populations in the study. Subgroup analysis for primary and secondary events was performed for a variety of pre-specified groupings and also exploratory analysis, and there was homogeneity within the response. There were no significant effects in any particular group showing benefits for AAV1 circuit 2A. Exploratory efficacy endpoints were also looked at, and for change in New York Heart Association functional class, percentage of patients who improved greater than 1 New York Heart class, distance walked over 6 minutes, KCCQ overall score, and N-terminal pro-BNP levels compared to placebo. Treatment with AAV1 circuit 2A had no significant effect on the change from baseline. Safety is shown in the next 3 slides. Overall, there were no differences in cardiovascular-related death between the 2 treatment groups. The Kaplan-Meier curves are depicted on this slide. Nor was there any significant difference for any of the clinical endpoints that one would look at in a heart failure population between the 2 treatment groups. A variety of clinical, biochemical, and ECG variables were looked at, and here also no safety signal emerged in this study. In summary, then, treatment of patients with moderate to severe heart failure with AAV1 circuit 2A did not significantly reduce the likelihood of either recurrent hospitalizations or terminal events, the primary and secondary efficacy endpoints of CUPID 2. There was no evidence of improvement for these endpoints in any predefined or exploratory subgroup, and there were no beneficial effects on exploratory efficacy endpoints. However, no safety concerns emerged. Our conclusion then is that CUPID 2 failed to support the hypothesis that AAV1 circuit 2A at the dose used has clinical benefits in patients with moderate to severe heart failure and reduced ejection fraction. While the results of CUPID-2 were disappointing, it does represent an important building block for gene transfer for the treatment of heart failure and raises a number of questions that need to be addressed. Questions about study design are shown on this slide. A fundamental question is whether or not gene transfer to improve the deficit in SERCA2A is adequate to improve clinical events in heart failure patients. In other words, does the data from the experimental animal studies translate to the complex milieu of patients with advanced heart failure? In order to answer that question, we must ask another fundamental question, and that is, was there adequate drug delivery to the cardiac myocytes? This is a complex question involving not only mode of delivery, but also dosing and the complex interaction of delivery of gene particles with viral particles in the milieu of human patients in the setting of heart failure. These questions need to be addressed, and it is the hope of the CUPID investigators that by presenting this data, this will stimulate further interest and debate, and future research will prove gene therapy to be useful in patients with heart failure. Thank you for your attention.
Thank you very much, Dr. Greenberg, for this very nice presentation. The discussant review will now be given by Professor Michel Komajda from Paris in France. Michel, please.
Professor Bax, Professor Yusuf, ladies and gentlemen, this is my disclosure slide. I would like first to congratulate Dr. Greenberg and co-workers for the conduct of this important clinical trial. Gene transfer in patients with heart failure has been under discussion for several years, and this novel approach has raised enormous hopes in the medical community. In that sense, CUPID-2, although of limited size, is an important step in heart failure research, and the important scientific, logistical, and financial efforts needed to conduct the trial until completion should be praised. However, CUPID-2 failed to meet its primary as well as its secondary objectives, and it is therefore necessary to try to analyze why it failed. I would suggest to the panel to consider 4 different potential points: the target, dose and duration of effect, delivery and vector, and finally, patients and outcomes. The concept. The rationale for targeting SERCA2 for gene therapy is strong. Abnormal calcium cycling is well demonstrated in heart failure, and one of the key components of calcium cycling dysfunction is the decreased expression and activity of the molecule responsible for the reuptake of calcium in the intracellular stores, SERCA2A. Indeed, preclinical studies have demonstrated that the increased expression of SERCA2A in cardiomyocytes is able to normalize calcium cycling, and that gene transfer of SERCA2A was able to reverse cardiac dysfunction in large animal models. Finally, hopes in the clinical setting were fueled by the publication of CUPID-1, an earlier study using the same transgene. In this study, 3 different doses of DNA-resistant particles infused intracoronary were tested against placebo. It was observed, as shown on this slide, that patients' well-being, cardiac function, and biomarkers were improved at 6 and 12 months after gene transfer, in particular in the high-dose group, without any major safety issue. Importantly, the investigators conducted a 3-year follow-up which showed improved outcomes in the patients treated by the high dose. Despite this body of evidence in the preclinical and early clinical setting, CUPID-2 failed to demonstrate any clinical benefit. And one potential explanation is the fact that calcium cycling is dependent on many other factors apart from CK2A, and or that exogenous CK2A produced by gene transfer faces post-translational modifications which could limit its efficacy in a potentially toxic intracellular environment within the failing cardiomyocytes. Dose and effect duration are other potential explanations. The dose used in CUPID-2 is the one which showed benefit in CUPID-1. Whether higher doses of transgene would be more efficient in promoting clinical benefit remains an open question. However, a potential issue would then be the induction of an immune response to the high-dose virally transduced cells. The persistence of transgene long-term is another question. Since access to myocardial tissue is challenging, this is not an easy task, and persistence of the transgene in CUPID-1 long-term could be ascertained only in 3 patients. It is therefore not possible to exclude the fact that the benefits of the procedure decline and disappear with time. Mode of delivery and vector. The mode of delivery used in CUPID-2 are the other points to consider. An antegrade mode of infusion into the coronary artery was used here, and the question arises whether a retrograde delivery could improve gene transfer into the myocardium. Recently, the Stop Heart Failure trial published in our flagship journal showed also that transendocardial gene transfer was feasible and safe. The vector used in CUPID-2 was a type 1 adenovirus. Other serotypes, including types 6 and 9, have been used preclinically, and recently, non-viral plasmid DNA has been safely used in stop heart failure. The promoter used in the current trial is a classical ubiquitous cytomegalovirus. More recently, cardiac-specific promoters, such as the myosin light chain, have been discussed for forthcoming trials. Finally, one has to consider the trial design and the population. The population enrolled in CUPID-2 had moderate to severe heart failure and was very well treated by modern standards. The endpoints used in the trial, focusing on heart failure endpoints and on major events, are accurate for this kind of analysis. However, the use of ambulatory worsening heart failure as part of the primary endpoint is arguable, since it is generally considered as a weak endpoint. The safety of the procedure was good, and no proarrhythmic effect was detected. The statistical analysis approach is complex, but it has been used recently in other clinical trials of small or intermediate size, and it encompasses all the domains of interest to be analyzed in this condition. Importantly, 60% of the pre-screened patients had to be excluded because of the presence of pre-existing neutralizing antibodies. This is obviously a major limitation for this kind of approach, since it rules out the majority of patients who could be enrolled in these trials. In summary, despite the disappointing results of CUPID-2, it is not time for discouragement. CUPID-2 simply tells us that the road to cardiac repair by gene therapy in heart failure is long, bumpy, and includes multiple hurdles. To conclude at this stage that it is a dead end would be a major scientific mistake. Different promoters, vectors, delivery methods, and potential targets should be tested in future trials. The necessary scientific and financial resources should continue to be invested in this research in order to better understand the interest of gene therapy in patients suffering of moderate to severe heart failure. Thank you.
Thank you very much, Professor Komajda, for this extensive interpretation. Dr. Greenberg, I myself just had two questions. One is you put your reduction level quite stringent. You aimed for a 45% reduction. Would you anticipate that if you set the boundaries a little bit less stringent, that would be resulting in a different effect? And my second question to you would be, as Professor Komajda indicated, you aimed at this moment in time at the patients with moderate to severe heart failure, whereas the ones with a lower EF, let's say below 35%, would you expect a different effect? These are the two questions that I would like to ask you.
Yeah, there are two excellent questions also. Sample size was based largely on the results seen in Cupid 1, where there was a substantial reduction in recurrent heart failure events. And we felt that moderating that and using that number for Cupid 2 would be reasonable. But remember, it was a 2B study, and there were constraints in doing a study like this. And in order to make it feasible, the decision to use a more stringent level was employed in this study. Had we used a different patient population, one doesn't know what we would have found. The reason these patients with more advanced heart failure were used is that we were looking at the effect on clinical events because we had already had a signal from the previous study, and using more advanced patients gave us a higher likelihood of these patients having clinical events.
Any other questions? If not, then thank you both again.
Thank you.
Our next presenter is Martin Cowie from London, and he's going to give us the results of the SERVE heart failure trial, which is adaptive seroventilation in people with heart failure and central sleep apnea. Martin.
Thank you very much indeed. It gives me enormous pleasure to present the results of this study on behalf of the investigators at 91 centres in 11 countries and 1,325 patients. I think this study is a simple hypothesis that we set out to test, and results surprised us completely. These are my disclosures. I'm also delighted to say that the New England Journal of Medicine shared our enthusiasm for the importance of the data. So this paper was published today, downloadable on your iPhones as you sit there if you want to look at all of the material and supplementary material also. If you'd like to ask me further questions, then there is a satellite symposium straight after this meeting in Moscow in Village 2. Now, just a brief word about the technology. You're all very familiar with CPAP therapy, or continuous positive airway pressure, where you apply the same pressure across inspiration and expiration. ASV technology is more intelligent than that. Yes, it has positive airway pressure, but it has servo-assisted variation in the pressure support. So the inspiratory pressure support is varied depending on the respiratory pattern. There's also a backup rate also. So this central sleep apnea pattern here that you would see in a heart failure patient, and the most characteristic that we're familiar with as cardiologists is Cheyne-Stokes respiration, you can see that by applying the ASV algorithm with a mask and ventilator, you can then get the ventilation back to a much more normal pattern, much more effectively treated by ASV than CPAP. So we knew that central sleep apnea was a very bad prognostic sign in patients with heart failure. We knew we had a technology that could alleviate central sleep apnea. We just wanted to prove how large the benefit was, and that's why we designed the trial. There have been several small studies, non-controlled studies, some small randomized trials that have been very promising with ESV technology in terms of the impact on surrogate endpoints such as ejection fraction, natriuretic peptides, and quality of life. We also had the benefit of a randomized trial with CPAP therapy, not ESV, but CPAP. Now, that was a neutral trial overall, the CANPAP study from Canada, published some 10 years ago or so now. But in a post hoc analysis, Michael Arts had shown that if they had suppressed the central sleep apnea with CPAP, it seemed to be associated with a remarkably better prognosis. So those were the background rationale for going on the SERVE-HF study. So as I said, the hypothesis was simple. Let's control the central sleep apnea in the right patient population and see what happens to the natural history of these patients. So this is by far and away the largest randomized trial in any aspect of sleep apnea to date. 91 centers in 11 countries, and optimal medical therapy for both groups, but in one group they were randomized to ESV in addition. It was titrated to the individual patient. The endpoints in the study are shown on the slide. A typical heart failure endpoint with time to first event of all-cause death, unplanned hospitalization for worsening heart failure, and also other life-saving interventions such as transplant or long-term LVAD implantation or resuscitation after cardiac arrest. We also had some secondary endpoints, and I'll come back to some of these, particularly all-cause death and cardiovascular death, but we also looked at the functional impact of controlling central sleep apnea, and by a variety of tools. Patients were chronic stable systolic heart failure, so the ejection fraction had to be 45% or below. Class 3 or 4 heart failure, so quite symptomatic, or if they were class 2, they had to have a recent heart failure hospitalization. And we wanted them to have central sleep apnea, so there's the criteria for that. So these are patients who had good going sleep apnea, which was predominantly central. We enrolled 1,325 patients between February 2008 and May 2013, and I'd like to thank the investigators, both respiratory physicians and cardiologists, for working together and to recruit this number of patients to a long-term trial. The age of the patients was around 70 years of age, and reflecting the epidemiology of central sleep apnea, they were predominantly male. The ejection fraction was low, as I've told you, and you can see that the therapy, background therapy, was very good, with very high usage of ACE inhibitors and beta blockers, and also a high use of device therapy. There was, by chance, an imbalance in the antiarrhythmics, with more antiarrhythmic drugs used in those allocated to ASV therapy. What did we achieve? Well, looking at a surrogate, looking at the physiology, we certainly controlled the central sleep apnea. If you look at the figures, the apnea-hypopnea index was dropped from over 30 at baseline down to 6 or so. If you look at the apnea-hypopnea index, the central index, that was also extremely well controlled, 25 going down to 3 or 4. The oxygen desaturation, the amount of the dipping in the oxygen, also was improved. So there was no doubt that this therapy does control central sleep apnea. In terms of compliance or persistence with the therapy, 60% of patients used it for an average of 3 hours per night. And looking at other measures of usage rate, the average was between 3 and 4 hours per night at 3 and 48 months follow-up. So they were using it for a large stretch of the night throughout the trial, and certainly we were controlling the central sleep apnea. And that's why this is the surprise. Despite controlling the grossly abnormal physiology beautifully, this did not translate into a difference in the natural history of these systolic heart failure patients. This is the primary endpoint of all-cause mortality, life-saving cardiovascular intervention, or unplanned hospitalization for worsening heart failure. There's statistically no difference between these curves. Disappointing. However, the big surprise was here. Looking at the secondary endpoints, all-cause death, was elevated. Hazard ratio of 1.28, or 95% confidence interval between a 6 and 55% increase in mortality. There were 420 deaths in this study. This is a high-risk group of patients. There's a lot of endpoints contributing to these curves. Statistically speaking, p equals 0.01 for mortality. And if you then drill down to cardiovascular mortality, the hazard ratio, perhaps as you would expect now, is even greater, a 34% increase in cardiovascular mortality by controlling the abnormal physiology. In terms of symptoms and quality of life, we expected to see some improvement in this, but it doesn't really matter what measure of this, Euroqual, Minnesota, NYHA class, or even a 6-minute walk test. We could not detect any difference between the two groups. Only at the very end of the trial could we see a difference, and actually 6-minute walk distance declined more in those that had been allocated at baseline to ASV therapy. So what are our conclusions? Well, we're still trying to make sense of the data. It's a very intelligent editorial in the New England Journal, which I'd advise you to look at. We certainly can say that adding this therapy to guideline-based medical therapy for systolic heart failure patients cannot be recommended on the basis of this randomized trial. We do control the physiology, but there's no benefit to the patients. We also have to be concerned about the increase in cardiovascular and all-cause mortality. This is inconsistent with some small previous studies, and there may be several mechanisms for this. Simply put, maybe positive airway pressure is not so good for these patients, but there's a lot of evidence against that. Another hypothesis is that Cheyne-Stokes respiration is not anything other than a compensatory and adaptive mechanism that is of benefit to patients with systolic heart failure, and getting rid of it might cause harm. We don't know the answers to these questions. We have a lot more data to go through in our study, and there are many other ongoing studies which will add to the evidence base. Thank you very much indeed.
Thank you. Dr. Poppas?
Thank you very much. I'd like to first commend the investigators for a really excellent trial, well performed, and using hard endpoints, a difficult trial. I have no disclosures pertinent to this topic. So as we just heard, a very well-designed trial, and again, the investigators should be commended for this. It was large and adequately powered to really look at the endpoints that are important. It was randomized well and looked at hard endpoints and not just the surrogate markers that we'd seen in previous trials. Also importantly, this population is generalizable to the other heart failure patients that are in our general practices. It was predominantly male, but we see that in heart failure patients, particularly with central sleep apnea. They had adequate and very optimized medical therapy, as we heard, with the high use of devices. The hypothesis appeared to be quite valid from all the data we had prior. We'll look into that a little bit more, and was clearly rejected. The primary endpoint was neutral, and the secondary endpoints surprisingly negative. So the conclusion is valid that ASV to treat predominant central sleep apnea in patients with heart failure with reduced ejection fraction on optimal guideline-directed therapy did not improve cardiovascular outcomes and did appear to increase mortality. So let's look a little bit at some of the background, the putative mechanisms, and some of the other trials to put this in perspective, and then have some take-home messages, hopefully. Well, sleep-disordered breathing is incredibly common. It's a common comorbidity, and central sleep apnea has been reported in 25 to 40% of patients with heart failure with reduced ejection fraction. 50% of outpatients and up to 74% of patients that are admitted with heart failure have sleep-disordered breathing, the combination of both obstructive and central sleep apnea, and they commonly occur together, but need to be differentiated. So is sleep-disordered breathing a marker of disease? Clearly, yes. Sleep-disordered breathing has been shown to independently predict mortality. But importantly, the mechanism isn't clear. Is it direct effects of hypoxia and adrenergic surge? Is the central breathing adaptive, as has been suggestive? Or is it simply a marker or precipitant of more severe heart failure? So the question of treating central sleep apnea to improve survival has been shown to be no. What are the possible mechanisms? Without sending us back to medical school, just remember that central sleep apnea and Cheyne-Stokes respiration are this cycle of hypocapnia, apnea, hypercapnia, tachypnea, and hypocapnia again. It has been shown to be attenuated by a number of different factors, importantly including guideline-directed medical therapy and CRT. There's clear negative effects of central sleep apnea. As mentioned, the adrenergic surge and hypoxia may lead to disease progression. The negative intrathoracic pressure may affect wall stress and afterload, and CPAP and other positive pressure ventilation may unload the respiratory muscles and presumably reduce LV afterload and be beneficial for heart failure patients. But importantly, CPAP in particular has been looked at and can reduce the cardiac index in healthy subjects and in heart failure patients when the filling pressure, the preload, or the wedge is low. So let's look at that a little bit and compare it to some of the other trials. As was mentioned, there was a meta-analysis looking particularly at ASV compared to a variety of other treatments, either BiPAP, CPAP, or medical therapy. There were 14 studies, mostly small, some uncontrolled. And there was shown to be an improvement in surrogate markers, such as BNP and LV ejection fraction, as was mentioned. And then, again, the Canadian CPAP trial, which was a randomized trial over 2 years, again showed an improvement in surrogate markers, but that did not translate into a survival benefit. Importantly, in that trial, there was a trend for early mortality actually in the CPAP patients, and that at 18 months it crossed over, and there tended to be a trend for mortality later in the control patients. So perhaps we're looking at something similar. A post hoc analysis, which is one of the impetuses for this trial as well, showed that the well-treated patients within that trial, when compared to controls, showed an improvement in ejection fraction, and with a P of 0.04, an improvement in survival. But that group of patients that were well-treated were on the same, again, it was a post hoc analysis, and it was 57 compared to the other 43. And so is that a treatment response or perhaps a marker of disease? Is central sleep apnea a marker? And that's what we're seeing rather than a treatment effect. So what is our take-home message, and what should we do when we leave here today with our heart failure patients who have central sleep apnea in particular? At present, from the trial today, we have evidence that there's no indication to initiate ASV ventilation to improve morbidity or mortality for heart failure patients with reduced ejection fraction. Perhaps we should assess all of our sleep apnea patients who are on ASV who have a reduced ejection fraction and consider discontinuing this. For our heart failure patients with preserved ejection fraction, we do not have data for harm and should be able to preserve a watchful wait. So in summary, the treatment for patients with central sleep apnea, optimizing guideline-directed medical therapy and CRT, nocturnal oxygen has been shown to be beneficial and has not been shown to be harmful. And then the question remains, and perhaps the panel could weigh in on this as well, judicious use of CPAP for OSA symptoms only, not necessary mortality. Thank you.
Thank you very much, Dr. Cowie and Dr. Poppas. These are important results that have implications for clinical practice. Clearly, based on your data, we shouldn't be routinely taking people with central sleep apnea and subjecting them to this intervention. But having said that, this is a strategy, and there can be various approaches to the intervention. Two questions. Is it possible that the same general strategy, but with different approaches to it, of settings and durations and timings might make a difference? And the second is there are other trials going on right now, while your data are very powerful, what would your advice be for those who are doing the trials?
Well, despite the results of our trial, I think it's absolutely essential we have more evidence in this area. This is very important. We do not understand what's going on here, or the pathophysiology, so we need more evidence, not less evidence. But I absolutely agree with you. The take-home clinical message is if you've started to use ASV for central sleep apnea and systolic heart failure, please stop, and please counsel your patients if they're on it about the fact that they have nothing to gain from continuing with the therapy. That does not mean, of course, that we know the answers to, as Athena said, diastolic heart failure, no idea. Obstructive sleep apnea, very common syndrome, we don't know the answer to that as well. And I think it's important to think about the therapeutic goal. For obstructive sleep apnea at the moment, generally, it's for treating daytime sleepiness, which can have a huge impact on a patient's life and safety in driving. And I think we don't provide any data for that space. So absolutely, we need more trials. And as you say, they're ongoing. And I really look forward to seeing more data to add to this evidence base.
Yep. Excellent study. And thank you both. Study emphasizes the importance of clinical outcomes as opposed to surrogate outcomes and doing careful randomized trials as opposed to basing clinical decisions solely on theory. Thank you, an important contribution.
Right-hand target over to you, my friend.
So the next presentation will be given by Dr. Morillo from Hamilton, and this is the benefit trial. Please.
Thank you very much, Professor Bax, Professor Yusuf. It is my distinct pleasure to present on behalf of my co-principal investigator, Dr. Jose Antonio Marineto, all the members of the steering committee, and all the investigators of the benefit trial, the bisnidazole evaluation for interrupting trypanosomiasis benefit trial. These are our disclosures. This trial was funded primarily by the Population Health Research Institute at Hamilton Health Sciences and McMaster University in Canada, a couple of grants from the Canadian Institutes of Health Research and the WHO Tropical Disease Research, and some funding from the Faculty of Medicine at the University of Sao Paulo in Ribeirão Preto in Brazil, and the Ministry of Health in Buenos Aires, Argentina. As you may know, Chagas disease remains being the third most common parasitic disease globally, only after schistosomiasis and malaria. The most common form of non-ischemic cardiomyopathy in Latin America is due to Chagas disease, and it's been estimated that globally anywhere between 5 to 7 million people are infected. Of note, between 1.4 to 2.1 million people will develop cardiomyopathy within 20 years of being infected with the etiologic agent Trypanosoma cruzi. We do not understand exactly why the parasite leads to cardiomyopathy. However, there is evidence that D. cruzi low-level parasitemia may directly or through an inflammatory autoimmune mechanism lead to cardiomyopathy. Based on this rationale, we felt that the role of anti-trypanocidal therapy in Chagas cardiomyopathy is unknown, and thereby we designed the benefit trial with the following objectives. The primary objective of the benefit trial was to evaluate whether the use of the trypanocidal therapy with bisnidazole reduced mortality and reduced the progression of in Chagas cardiomyopathy patients. Our secondary objectives were to determine the effects of bisnidazole on parasite detection rates by conventional polymerase chain reaction, or PCR. And we were also interested in evaluating the safety and tolerability of bisnidazole in this population. The study was designed by the steering committee, and we included patients that had chronic Chagas cardiomyopathy that were between the age of 18 years to up to 75 years. They had to have at least 2 different positive serological tests for T. cruzi and typical ECG abnormalities, at least 2 of these, which are generally right bundle branch block, left vesicular amiblock. We excluded patients that were in New York Heart Association class 4, but included the rest. The trial randomized patients to bisnidazole in a maximum dose of 300 milligrams daily for 40 to 80 days, depending on weight, and with matched placebo. We follow up the patients at 11 and 21 days, and at the end of treatment at 6 months, and then every year until the end of study, and we had a mean follow-up of 5.4 years. The primary outcome was the time to first event of a composite that is described in the slide that included death, resuscitated cardiac arrest, sustained ventricular tachycardia, insertion of a new pacemaker or implantable cardiac defibrillator, cardiac transplant, new or hospitalized heart failure, stroke, TIA, or any other thromboembolic complication. We, as indicated, randomized patients to bisnitasol or matched placebo for 40 to 80 days, and we collected adverse events, liver function tests during the treatment period, and 12-lead ECG annually. We also did echocardiogram at baseline, 2 years and final visit, but I'm not presenting the echocardiogram data in this presentation. We collected blood samples for qualitative conventional PCR in 1,896 patients at baseline to detect circulating T-Cruzi kinetoplast DNA. At the end of treatment in over 1,500 patients, at 2 years in over 1,500 patients, and at the final follow-up, it was at mean more than 5 years in another 1,500 patients. The study was conducted in 49 centers in 5 countries in Latin America, 1 in Central America, El Salvador, and the rest in South America. Study Global Coordinating Center was in Hamilton, Ontario, Canada, the Population Health Research Institute, where I am a member of, and we had patients in El Salvador. The numbers in parentheses are the numbers of patients recruited in each country. Brazil recruited the majority of patients, almost 48% of the patients. Colombia, Bolivia, and Argentina, so 5 countries participated in this trial. We had 3 PCR core labs that were in Argentina, Brazil, and Colombia, and in Colombia, the samples from Bolivia, El Salvador, and Colombia were analyzed. We had a central core lab for our echocardiograms that was hosted in the University of Sao Paulo in Ribeirão Preto in Brazil, and our Latin American Coordinating Center was at the Research Institute in Dante Passanese in Sao Paulo, Brazil. This slide summarizes the flow and the adherence to treatment. As indicated, we randomized 2,854 patients, 1,431 received bisnitasol, and 1,423 placebo. 84% of the patients assigned to bisnitasol received at least 75% of the target dose indicated, in comparison to 90% in the placebo group. We had 13.4% that discontinued therapy permanently in the bisnitasol arm, compared to 3.6%, or 51 patients, in the placebo arm. Of note, we completed follow-up with a mean follow-up of 5.4 years in 99.5% of the patients. Remember that this was a trial conducted in remote areas in South America, so I think this is a huge achievement, and we should be very grateful to our investigators. 1,431 patients were analyzed in this intention to treat in the bisnitasol arm, and 1,423 in the placebo arm. This slide summarizes the baseline characteristics between the 2 populations studied. The mean age of this study population was around 55 years. 93% or more had abnormal ECGs with the abnormalities I mentioned previously. Approximately 10% had previous history of heart failure, and the vast majority were in the New York Heart Class 1, 75%. The mean left ventricular ejection fraction was 55% in both groups, with wall abnormalities that are also typical of Chagas seen in approximately 40% of the cases. Medications used for heart failure were primarily diuretics in about 30%, an ACE inhibitor or an ARB in half of the patients, beta blockers in 31% of the patients, and amiodarone in 20% of the patients. This slide summarizes the findings on the 1,896 patients that at baseline had a positive PCR and the negativization rates. In the upper panel, you can see the overall rates in the 5 countries included. At end of treatment, you see a 66% reduction in a negativization rate compared to 35% in placebo. At 2 years, 55%, and more than 5 years, 46%. Of note, the type of response differed a little bit between the different countries, and these are coupled based on what we know that is the assumption of the most prevalent type of parasite in each one of these countries, being T. cruzi 2 in Brazil, T5 and 6 in Argentina and Bolivia, and T1 in Colombia and El Salvador. This was highly significant, and there was an interaction p-value of less than 0.01. A primary outcome that it was the composite of death, resuscitated cardiac arrest, sustained ventricular tachycardia, new heart failure, stroke or embolism, and pacemakers or ICDs did not differ among the two populations. Of note, there was a slight separation in the curve after 2 years, but after 7 years of follow-up, we didn't find any significant difference. The hazard ratio was 0.93. And as you can see, the log p-value was 0.31. We did adjust for disease severity based on different findings that we had, and we could not find any significant differences in the primary outcome. These are the primary outcome components in which we also did not find any significant differences among neither of the components. You see that in death, we had over 500 deaths throughout the study conduct, with 17% in bisnitasol and 18% for a hazard ratio of 0.95. Any of the arrhythmic events, such as cardiac arrest, sustained VT, or receiving a pacemaker or ICD, were not significantly different. The heart failure events, either heart failure or receiving a cardiac transplant, or the stroke and thromboembolic events, none were significantly different among our population. We conducted several subgroup analyses of pre-specified subgroups that have been identified to identify or be markers of severity of disease in Chagas cardiomyopathy, including the country of origin and presumed based on the most prevalent type of T. cruzi, and there was no interaction at that level. Whether the PCR was positive or negative at baseline didn't show any significant change. Age, gender, the severity of the disease, or LV ejection fraction under 40% or greater than 40%. As you can see, none of these showed any significant heterogeneity. Other subgroups that we analyzed were also related with other echocardiographic and electrocardiographic markers that were negative. And of note, the only subgroup of these 12 that was significant was the amiodarone that showed an interaction p-value of 0.08. And this may be due to multiple issues that we may discuss if you want at the time for questions. The safety and adverse events are summarized in this table, and they show that we had about a 24% rate of any adverse event. They were all significantly higher in the bisnitasol group. Permanent discontinuation was lower than what has been previously reported at about 13%, hypersensitivity and 11%, and the most frequent being cutaneous rash. We only had about 5% that had more than twice increase in the upper lower limit of the liver function test. So in conclusion, the benefit trial showed the bisnitasol with the dose used in a 40 to 80-day course in patients with established Chagas cardiomyopathy did not significantly reduce clinical progression despite significantly reducing PCR blood T. cruzi detection. Bisnitasol was well tolerated and permanent discontinuation was lower than previously reported. I'd like to, if you want more details, you can go to the New England Journal of Medicine today. This trial was also published online, and you can also find the editorial and all the data for the trial. And I'd like to thank all of our steering committee, the Data Safety Monitoring Board, and both the global and local coordinating centers and all the people that help us. And of course, all the many investigators that worked for over a decade in this very important trial. Thank you very much.
Thank you very much again for this presentation. And the discussion will be taken by Professor Ponikowski from Poland. Piotr, please.
Two things. First, I would like to congratulate the investigators for conducting such an important and great trial. And I would like, on personal note, to thank the Program Committee of the European Society of Cardiology to invite me to discuss this trial. This is my disclosure. I would only love to treat such patients. I think that heart failure landscape at the beginning of 21st century has dramatically changed, positively changed. We are not longer saying heart failure is inevitably leading to death. Now heart failure is treatable and preventable disorder. However, we need to admit that the current knowledge base of heart failure epidemiology is mainly derived, I am sorry to say, from non-representative sample of countries, mainly including non-North America and ESC countries. And we are very much aware of the regional differences in etiology, natural course, and the management, and obviously the outcomes. This is the background why ESC Heart Failure Association set up the initiative we are calling the Global Heart Failure Awareness Program in order to support the coordinated effort to make heart failure a health priority in every country across the globe. And I would like to thank the investigators for so much contributing to this initiative by giving us the data from the trial. As you heard, chronic Chagas disease is a really challenging problem with around 6 million people being infected, with around 1/4 of infected developing cardiomyopathy within their lifetime, and even more importantly, that cardiac involvement is the main cause of the death in chronic Chagas disease. For all those of you who are not dealing with Chagas like myself on an everyday basis, I would like to give you a little bit of background to convince you that the approach the investigators did is very attractive and worthy to investigate. This is the schematic view of the main pathogenetic mechanisms in chronic Chagas cardiomyopathy, and whichever way we are going to discuss, there is a general agreement that the parasite persistence is central to the disease. We don't know whether this is direct or indirect effect. However, there is a need to search for anti-parasite treatment with high efficacy during the chronic phase. You have seen the presentation, and we are all a little bit disappointed with the neutral results of the trial. However, I would like again to congratulate the investigators for their preciseness in the assumption. It only convinces me that they are really treating these patients and they know the story very well. The original assumption was yearly event rate 8%, non-compliance 17%, and loss to follow-up 3%, and they achieved exactly what they planned. And once the study was presented, we discussed this with Karl, and we can only congratulate that loss to follow-up is 0.5%. This is really an enormous achievement. However, we are all trying to answer the question why the trial is neutral. The question was posed because, unfortunately, all the trials presented today were neutral. So either wrong underlying pathogenetic concept, perhaps ineffective drug, and wrong population. Let me start with the concept and with the drug. I am not the expert, but looking at the data, I truly believe that the drug may well be not effective addressing the pathogenic idea and concept. For your perusal, there is no definitive test to determine efficacy. So we are not aware that even if we have negative PCR data, whether these patients are cured. This is only indication of the absence of circulating DNA once the blood is taken. We know the other part of the story, that if we have positive PCR, this is a marker of treatment failure. If you looked at the data, you can see that these patients were not treated in general, because even being treated does not guarantee you to be successful. This is a relatively short period of time. So the question of treatment, so the question for the future is whether complete parasite elimination would be what we really want to achieve, perhaps with something different. The other issue is about the population. I have borrowed the data from another paper quite recently published in New England Journal of Medicine and placed the patients in the category of the risk of death. And it looks like that these patients were in the intermediate category, as you see here. They were most in class 1 with well-preserved ejection fraction. And here we may argue both ways. Either we should go to this direction, to patients in high risk. However, I presume that the real challenge in Latin America is those who are affected but not yet developed signs and symptoms of the disease. And it may well be the next step. However, I truly believe that there was not a wrong population because it reflects what is going on in Latin America. So what can we, if at all, but I believe we can, learn from this neutral trial? I think that we can learn that the specific way patients with Chagas disease are now treated in the everyday practice is actually ineffective. The second issue is that this is the biggest ever trial in Chagas disease, and there is a great insight into the natural history and very importantly, the network of centers and expert investigators for future studies to continue. But the question really is how to prevent and how to treat Chagas disease in everyday practice. I have borrowed this slide from another recently published paper showing that actually beta blocker therapy to slow down the heart may well work. I know that the investigators, the physicians may well be a little bit concerned with using beta blockers, so maybe the alternative hypothesis is to slow down the heart with ivabradine. But to make long story short, I think to answer this question is simply, once the disease is there, the treatment tested in the trial was neutral, so we simply need to follow the ESC guideline. And I truly believe that we need to continue with the clinical trials, although we presume that something may well be effective, it sometimes is neutral or even detrimental. Thank you for your attention.
Thank you very much, Professor Ponikowski. So I'd like just to ask to Dr. Morillo, how do you see the next step for the future? What do we offer to these patients?
Yeah, well, that's a great question. I think that, we did show a couple of important things. First, we showed that benznidazole is a drug that is safe and it's tolerated, and it does have activity against the parasite. Not as much as we wish, so maybe we need it, as Professor Piotr here just mentioned, give more treatment, repeated pulses of treatment, like with other infectious disease like TB or leprosy, in which people receive more treatment. Again, we do not have the perfect test to determine cure, but we're working on that. On the other hand, the question is that remains, and probably the next trial is, we should probably definitely intervene in patients that are in an earlier stage and probably create a larger trial looking at this question in patients that are not as advanced.
Thank you very much. Oh.
Congratulations, Dr. Morillo, for this very interesting trial. Is it possible that the neutral results result from the fact that there would be reinfestation by the parasite in your patients?
Yeah, that's an excellent question. We didn't have time to show all the data, but we did collect data on the housing of the patients, whether there was the potential for reinfection or not. The way Chagas is evolved today, even in South America, it's more of an urban disease, not so much in rural. We only had less than 3% of the housing that were felt to be still infested by the triatomine. So reinfection is probably not the case. I think is not enough efficacy of the medication that has been shown that is not as powerful in the more chronic stages. Maybe because the parasite has already been embedded there for so long. Maybe we need pulses, more therapy, etc.
Thank you very much. I would like at this moment in time thank all the speakers, all the discussants, the panelists, my co-chair. And with that, I would like to close Hotline 5 on heart failure. Thank you for your attention.
Interesting. Perfect. 1 minute ahead of time.
This can't be right. This can't be right. I'm a human wrecking ball, and you're the love grenade, and we leave a trail behind us. There's a place I go to when no one knows me. It's not lonely, it's a necessary thing. It's a place I made up, find out what I made of. The nights I've stayed up, counting stars and fighting sleep. Let it wash over me, I'm ready to lose my feet. Take me off to the place where one reviews life's mystery. Steady on down the line, lose every sense of time. Take it all in and wake up that small part of me. Day to day I'm blind to see and find how far to go. Everybody got their reason, everybody got their way. We're just catching and releasing what builds up throughout the day. It gets into your body and it flows right through your blood. We can tell each other secrets and remember how to love. Da-da-dum, da-dum, dum, da-dum, dum, dum, da-dum, dum, da-da-dum, da-dum, dum, da-dum, dum, dum, da-dum, dum. There's a place I'm going, no one knows me. If I breathe real slowly, I let it out and let it in. It can be terrifying to be slowly dying, also clarifying. We end where we begin, so let it wash over me. I'm ready to lose my feet. Take me off to the place where one reveals life's mystery. Steady on down the line, lose every sense of time. Take it all in and wake up that small part of me. Day to day I'm blind to see and find how far to go.
Five, 4, 3, 2, 1.
Now.
Now.
Now. Now. Right now.
Really right now.
Tune into ESC TV.
Now. For you. all what you need.
Oh, I thought that I could change you. Oh, I thought that we would be the greatest story that I tell. I know that it's time to tell you it's over, but I don't wanna love somebody else. No.
I'm a little crazy on you. I can't help myself. Tell me, what am I supposed to do? And you're a little hard on me. Guess you don't want me to see how honesty gets the best of you, baby. Say you don't mind one way or the other, whether we're apart or we're together. Think they're so cool with your whatever. You put on quite an act, but babe, I know you better than that. Look at me and then you look away, as if there's a price to pay for giving me a little time. Still you follow me around as if I'm the only face in the crowd. I'm your every sight, I'm your every sound. You say you don't mind one way or the other, whether we're apart or we're together. You think they're so cool with your whatever. You put on quite an act, but babe, I know you better than that. Come on, baby, give it up, give it up. Come on, baby, give it up, give it up. Oh, you say you don't mind one way or the other, whether we're friends, whether we're lovers. You think they're so cool with your whatever. You put on quite an act, but babe, I know you better than that. You put on quite an act, but babe, I know you better than that.
It's hard to see when the smoke clouds over your eyes, and you lose focus as you're losing all your time. And there's one last thing to do that's waiting there on you. from this circle, leave it behind.
Five, 4, 3, 2, 1.
Now.
Now.
Now. Now. Right now.
Really right now.
Tune into ESC TV.
Now. For you. All what you need.
Waiting on somebody else to show me how a single spark can catch a light, and one you thought could change your life. So take the leap and trust you'll reach the other side.
Daydreamer sitting on the sea, soaking up the sun. He is a real lover of making up the past and feeling up his girl like he's never felt a figure before. A jaw dropper looks good when he walks, is the subject of their talk. He would be hard